Hi everyone. Welcome and thank you for joining us. My name is Almira. I'm a fourth year at the University of Illinois in Chicago, and together with Hazel, we will be moderating today's session. This is one of the many faculty-led board review sessions via RAD Discord. Shout out to Grace Sue, who created the RAD Discord server, which made all of these possible, basically. We are honored today to be hosting Dr. Jeffrey Kanne for a chest board review session. He is a professor of radiology and chief of thoracic imaging at the University of Wisconsin-Madison. He was named fellow of ACR this past year, so congratulations on that.
Thank you.
Dr. Kanne. So he is an authority in thoracic imaging with 100+ published articles and many book chapters. He is also deputy editor of Journal of Thoracic Imaging, and these are only just a few examples of many of his academic honors and appointments. But the way I know him is through Society of Thoracic Radiology. Most of us are familiar with this society because they have core curriculum for chest and cardiacs with many high-yield video lectures there. However, STR also hosts weekly case conferences on Wednesdays. A couple of knowledgeable thoracic imagers across the country gather together, they share cases and discuss the cases. And Dr. Kanne is one of the active members of that group. And he does also a fantastic job in uploading all the recordings of the sessions to his YouTube channel. So you should definitely check that out. They have 5-star, thought-provoking discussions. And in my opinion, no matter what level of training you're at, you'll learn something there. So after boards, definitely check it out. I think it's like two weeks before board. This like we should have been doing that, but yeah. So we're happy that he is joining us today. All right. So now before we start, I'm gonna turn to Hazel to discuss some logistics.
Thanks, Almira. Hey guys, I'm Hazel Asumu. I'm a R3 from Vanderbilt. I think I've met a lot of you guys by now. So I'm just going to go over some logistics. I'm going to be co-moderating with Almira. This is going to be a hot seats case-based review as we've had in the past. I'm going to be calling upon a resident to take 3 cases at a time. And if you have any questions, you can put them in the chat box. And just to kind of keep things going without too much interruption, we'll be taking questions at the end. So yeah, with that, Dr. Kanne, we can go ahead and get started.
All right.
I'll stop sharing here.
There, you should see my screen. Okay.
So our first resident to take cases will be Grace from University of Utah.
Okay.
All right. Okay, so it looks like we have an AP and lateral chest radiograph. And we can see that there are kind of patchy, looks like patchy opacities kind of in the bilateral upper lobes. I wouldn't say, I don't know if they're like really, I'm kind of wondering if like there's more dilated airways in the middle in between them. So I'm wondering if this is like some sort of bronchiectasis, maybe upper lobe predominant bronchiectasis. So wondering about like, does this person have like cystic fibrosis or something along those lines?
Yeah, what else could be besides dilated airways, for example, these areas here?
Yeah, I guess if you, then another thought is like if they were coalescing a little bit more or something like that, like I think about like PMF or something like that. And I always think about like upper lobe predominant disease, like with tuberculosis and stuff, right, and infectious.
Okay. So here's the CT.
Oh boy. Okay. All right. So CT axial looks like lung windows, and we can see kind of the same, like almost like central lobular kind of consolidated opacities in the bilateral upper lobes, and we can see like these cystic looking spaces. Without scrolling through, it's hard to tell like are these truly connected to the airways, or are they like just cystic like pneumatoceles or something like that. So I think it's not really quite. It doesn't scream cystic fibrosis to me. I'm thinking something along like lines of more infectious
Right.
infectious disease. So I'd be like really concerned, like could this be tuberculosis or some
Perfect.
cavitary?
Yep. This is TB. Yeah, these are cavities, and they do communicate with the airways. That's not uncommon. But the clue to the infection, as you see, like you mentioned, the small nodules, the so-called tree and bud. The other thing that should steer you away from CF is notice the remaining lung is normal. And with CF, you should see a lot of air trapping, and also the bronchiectasis is a lot more, should affect all the lobes primarily. So good. Excellent. All right, next case.
Okay. Okay, so we're taking you. Okay, got it. So we have an axial CT of the chest, and we can see a coronal CT of the chest. And here we see multiple nodules throughout the lung parenchyma. I would say that they're more. Let me see. There's definitely some along the periphery, along the subpleural space, and then there's also some in the central lobular distribution. So I would say this is like more of a random distribution rather than like a necessarily peri-lymphatic. So I guess when I think about that, I know we can like think about, so pneumoconiosis tends to start off like more central lobular, and then they tend to go to more of a peri-lymphatic distribution. If am I off with the distribution, by the way?
You're sort of there. Yeah. So you picked up on the subpleural nodules, right?
Yeah.
So, and there's some that are central, but most of them are sort of clumping around the bronchovascular bundle.
Okay, so this is then this would be more of a peri-lymphatic distribution.
Right.
So I think sarcoid could definitely do this, and then other pneumoconiosis could also do this as well.
Yep. And that's really about it. And notice the upper zone distribution too. That would sort of go against random, which is usually a hematogenous spread of either tumor or infection. And the fact that it's so upper zone favors an inhalational process rather than a hematogenous process. Another clue to peri-lymphatic is the clumping of the nodules. So like, for example, you can imagine this is probably a couple of nodules. They're clumping around here. I find that one of the most useful findings, and I can't find it written down anywhere in any books or anything. So that's my little pearls. Clumping of nodules should really suggest peri-lymphatic. Yeah, this ended up being silicosis, but if you had to pick one, you pick sarcoid because it's just much more common.
Okay, got it. Thank you.
Yeah, good. Okay, and then I think we're doing 3, right? Yeah, here's the third one.
Okay, so here, first thing I want to say is just like kind of diffuse ground glass opacities. It just like in general, the lung parenchyma looks just a little bit more ground glassy. And then there's these cystic spaces, predominantly looks like upper lobe predominant, and then maybe some faint hint of central lobular nodule. So I'm wondering if this is Langerhans cell histiocytosis.
You'd be exactly correct, right? And so, what does this patient likely do?
He probably smokes.
Right, and that explains. Right, and that would explain the ground glass opacities and central lobular nodules too. That's probably some smoking-related lung disease. Like remember, smoking, even though we think of the different smoking-related lung diseases, the injuries actually occur all the time in different parts of the lung, and it's just, and with LCH, for example, that's just the dominant feature in this patient. So yeah, this is a nice example of LCH, the classic bizarre cyst. They classically spare the bases, but I always put an asterisk by that. It's a relative sparing. You can always find 1 or 2 if you look closely enough and it's advanced enough. But this distribution in these irregular cysts is pretty much classic. So a favorite one on an exam because there's not really a differential for this. Okay, nice job, Grace.
Thank you.
All right, who's next?
Okay, next we have Eamon. She's an R4 from UT Houston.
All right, Eamon, nice to meet you.
Nice to meet you too. Thank you. Okay, so we have an PA and lateral radiograph. So there is this well-defined opacity projecting over the right upper mediastinum. What was that stripe called? Trachea. So it is associated with widening of the paratracheal stripe, I think. And I can see the lung markings projecting over it. So this looks like a mediastinal process.
Mm-hmm.
And I don't really see any other lesions in the lung parenchyma per se.
Yeah, the lungs look good.
And on the lateral radiograph, there is an anterior mediastinal opacity. So when I see this, I think about what could cause a mass in the upper mediastinum. It could be lymphadenopathy. It could be hematoma in the setting of trauma. It could be a primary anterior mediastinal mass. What else?
Okay. What do you want
It could
next?
be a vascular pathology like ascending aortic aneurysm.
Yeah. What study
those
do you
are
want?
I can think of. What is that?
What study do you want next?
Oh,
evaluate?
a CT with
Yeah.
contrast.
Yeah, some people do MR, but CT is really where you should start, I think.
Okay, so we have a CT with contrast right through the mass on the left, and then a little bit more inferior at the level of the pulmonary artery and right hilum. And we see this relatively homogeneous mass that is iso-dense to the muscle. That extends from the anterior mediastinum to the right hilum and also beyond the carina. So now my differential is down to either a anterior mediastinal mass, like a mass of thymic origin, or maybe a seminoma, or maybe lymphoma with extensive coalescent lymphadenopathy, or any metastatic disease to the mediastinum.
Okay, that's a great differential. So let's just talk a little bit about this. So back to the radiograph, right? The paratracheal stripe is abnormal. It has a smooth lateral margin, and that really suggests that it's not in the lung. It could be pleural or mediastinal. And then on the lateral view, you can localize it. It's pretty big, so it fills most of the retrosternal clear space and goes back a little bit. You need a CT to really to localize it. It's very homogeneous, and that should really point to the diagnosis. As well as notice the pulmonary artery passes through it and the mass effect is rather minimal. The SVC is still open. The brachiocephalic vein, we're not catching all of it, but it's not obstructed. We don't see a lot of collaterals, suggesting it's fairly soft. Mm-hmm. So what's the likely diagnosis when it's this homogeneous, soft sort of, and you mentioned it, it extends down and around everything. So it sort of just infiltrates the tissue without pinching stuff off.
As far as I know, that is typical for lymphoma.
Yes. Yeah, this is lymphoma. Yeah, seminomas or germ cell tumors are pretty rare relative to lymphoma, and they're going to occur in the prevascular space. This one extends a little more posteriorly, and they're pretty heterogeneous, whether they're teratoma type or they're non-seminomatous type. And then a metastasis, this confluent would be pretty unusual, and they're usually fairly necrotic. So homogeneous really, and like you mentioned, it's iso to muscle or close. So packed cells, high NC ratio really suggests lymphoma. Good. Next case.
Okay. Axial and coronal slices through the lung window. Lungs look a little hyperinflated. And there are these numerous, just want to make sure that's not emphysema. Yeah, there are these numerous cystic cysts throughout bilateral lungs. And the residual lung parenchyma looks actually pretty good. I do not see nodules. I do not see ground glass opacities. I don't see signs of chronic interstitial lung disease. So then I would be thinking about cystic lung diseases. I guess smoking history is important. The shape of the cysts do not look bizarre. They are more uniform. Looks like land to me.
Yep. Pretty classic, right? Diffuse, homogeneous cysts. They're pretty boring looking. They're all about the same. As you mentioned, the intervening lung is normal, and there's really nothing else. Classic LAM. So what other things might this patient have?
Tuberous sclerosis is a possibility.
And what might you see in the upper abdomen?
Oh, we may see the in the included portions of the kidney, we may see angiomyolipomas.
Right. And sometimes you'll even see them in the retroperitoneum outside the kidney. But yeah, that's exactly right. So there's two types of LAM. As you mentioned, tuberous sclerosis associated LAM, which is more common. And there's a so-called sporadic LAM, which is what this patient has. And it's a disease of female patients of childbearing age. The tuberous sclerosis can occur in males as well, but it usually doesn't cause symptoms. And they can present with spontaneous pneumothorax. So perfect case. All right. Is that 2 or 3? I've lost count already.
I think it's 2.
Okay. One more.
Okay. Axial and coronal images through the lungs. This time the lungs look very fibrotic, decreased lung volume, and there are these diffuse interstitial opacities both in the upper and lower lung zones. And the lung parenchyma has areas of air trapping. I don't really see bronchiectasis. I don't see honeycombing. I don't see any nodules. So, okay. So I guess this is not organizing pneumonia because it's not peripheral only. So what else can this be? So I guess if the patient has history of smoking, that would be alveolar proteinosis.
So you mentioned fibrotic lung disease, right?
Yes.
So let's talk about fibrotic lung diseases, because yes, there is fibrosis. There's volume loss. There's reticulation. There's traction bronchiectasis. You see a little bit of it there. And then you talked about the air trapping and that sort of the heterogeneity, right? You have some ground glass. There's some traction bronchiectasis. So you sort of have this heterogeneous background. So there's only a handful of fibrosing lung disease patterns, right? So can you take me through those? And I think you can arrive at the answer.
So I would exclude IUP because of the ground glass opacities and relative, absence of honeycombing.
And the distribution, right? It's not subpleural and basal predominant. So it's not UIP. Okay, good.
UIP, sorry.
That's all right. I knew what you meant.
NSIP would typically involve the lower lobes with ground glass opacities with subpleural sparing. It doesn't really look like textbook NSIP,
right?
Either.
Right. Okay. That's 2 of the 4 fibrosing patterns. You mentioned no nodules, right? And so if you think of upper lobe predominant fibrosis, particularly along the airways, that's fairly symmetric. Sometimes there's nodules with it. What do you think about?
So if there are upper lobe nodules, I would think about pneumoconiosis, I think.
Right. And what could look just like pneumoconiosis that's more common?
Sarcoidosis.
Yes. So, yeah, right. So this doesn't look like sarcoid.
So
there's one more, which this is going to be. So the air trapping is a big clue. So there's gray lung, there's black lung, there's a little bit of normal lung, and there's white lung. So you got this been described as like head cheese sign.
Oh, okay. Hypersensitivity pneumonitis.
Yes, good. This is fibrotic hypersensitivity pneumonitis. Some people call it chronic, but I think fibrotic's a better term. So you have a fibrosing lung disease. And so the first thing you do is it UIP or not? And it's not. It's not subpleural, it's basal predominant. Yes, there is subpleural fibrosis, but it's too central as well. There's way too much heterogeneity of the lungs. NSIP is strikingly basal predominant. I'd say about half the time, somewhere plus minus 10%, has the subpleural sparing. For an exam, they'd have to make it pretty obvious. Sometimes it does weird stuff. So yeah, we don't see that. And this has a lot of upper lobe disease, which would be unusual. Sarcoid is usually very symmetric along the airways, and you often will have a background of nodules unless it's really far gone. And then so if you sort of get this mishmash of different patterns, think of HP. It's often, I'd say about 80% of the time, it's upper zone predominant or at least asymmetric like this. But the air trapping, the lobules, very black, multiple lobes should be a tip off that you're dealing with HP. All right, nicely done.
Thank you.
All right.
Okay.
Next.
Next we have Elmira. She's an R4 from UIC.
All right.
Okay. Hi again.
Hello.
Hi. All right. We have bilateral apical mass-like opacities. The bilateral upper lobe. It looks like they have a halo around them, or maybe. And also they're also passing the clavicle. So we have posterior mediastinal masses, bilateral.
Well, could they be in the lung? Because notice there, you can sort of see the air around them.
Yeah, that was what I was thinking, because they're, so in
and
order.
Here they are on the lateral.
Okay, so on lateral, they look like are in the lung, because we should be having that not complete. If those were not in the lung, we shouldn't be having like a claw sign on the lateral view.
Right, and also they're too peripheral to be in the mediastinum. Yeah, so you have bilateral lung masses. And what else do you notice about the lungs?
All right, there are some reticular opacities on the upper lobe dominant reticular opacities. And
it may be hard to see on the internet, I apologize, but there are also tiny little dots all in here. You can see it's kind of a little busy in here.
Okay.
And then notice the hyla. Where are the hyla?
Those are like pulled up.
Correct.
So we are dealing with some traction bronchiectasis, probably upper lobe dominant, and some masses that looks like in the lung. So I'm thinking, what if these are these the only images that I'm gonna get, or am I gonna get CT?
I was gonna see if you got it off the radiograph, but I do.
Well, all right. I was going to say if those are like masses, like mystomas in the cavities bilaterally, but now I have. Oh, okay. So I think this is worse than I was thinking, and these are probably progressive fibrotic mediastinum. Like, what is progress? So the one that happens with silicosis gone bad.
Progressive massive fibrosis, or PMF. Yes, it's exactly what this is. Yes, so they can look pretty round on radiographs. They tend to have smoother margins. So the clue, because I see what you're talking about, it could sort of look like a mass with a lucency around it. Is it in a cavity? But you don't really make out a cavity wall. The background lung, even if you can't see the dots, is abnormal, and there's volume loss. So that's a clue that it's probably a fibrosing process or some kind of scarring process. The CT, though, right, you see the large masses, you see the background of small nodules, and that's key to make this diagnosis. You have to have the background small nodules. And then you can see a little bit of calcium in the lymph nodes, which is just additional. So this was complicated silicosis. Very good. So this could also be co-workers pneumoconiosis. They're indistinguishable by imaging. And occasionally sarcoid will give you this look. So if I were writing an exam question, I'd have to make it very clear that this was an exposure. Otherwise, sarcoid would technically be the right answer, even though this is pretty textbook for PMF, just because sarcoid is orders of magnitude more common than either silicosis or co-workers pneumoconiosis. All right, next case.
All right. So you are showing me an airway disease. You're asking me airway disease by showing me the trachea and the crina, and also the minimum intensity projection. So we have tracheal narrowing throughout, and it doesn't look like the posterior, the membranous portion looks fine. I don't think that this is it, because it's it looks fine. So therefore I'm not thinking of any of those that the ones that like Wegener's or the other ones that happens all around.
Okay.
So either I have that the one with long name, that but or I will go with the relapsing relapsing polychondritis, and I would choose that because it is not it doesn't have like so many nodular things and calcifications that happens with the other one.
Right, you're absolutely right. This is relapsing polychondritis. And yeah, the first observation is there's diffuse tracheobronchial narrowing. So RPC is a diffuse process. Only the cartilaginous portions are involved. And you notice that's too thick. If you look at enough CT scans over time, you recognize this is the normal wall thickness, even for cartilage. And it's got more amorphous calcifications than we typically see. One of the best places to look is at the carina at the right main bronchus, because there's usually lung behind it, so you get a really good view of that membrane, and even the bronchus intermedius and right upper lobe bronchus. So sometimes if it's a really thin patient, there's not a lot of fat between the esophagus and the trachea. So that's one of my favorite places to look, is right there. And it's sparing. So there's only 2 diffuse processes that spare that posterior membrane. The one that what the long name is called tracheobronchopathia osteochondroplastica. And they should never put that on an exam, because while that process, it's a formation of hyperplastic nodules in the submucosa. So they're going to cause little indentations. And actually, I see it all the time in patients. It's just very subtle. I never mention it because it just confuses people, and it's not worth mentioning. I can tell you in 20 years, I have seen one case ever with big enough nodules to actually poke into the lumen enough to cause problems. And it's very few people see enough cases. So it's not something to worry about. So if you see sparing of the membrane, go with relapsing polychondritis. It should be a diffuse process. If it's circumferential, then you think about amyloid, granulomatosis, polyangiitis, inflammatory bowel disease. There's a handful of other things too. Sarcoid, rarely, but it does do it. And then amyloid will be diffuse, like the entire trachea and airways are usually, and bronchi are usually involved. GPA, or used to be Wegener's, is skip lesions most commonly, TB, anything like that. And then if it's just one focal area, you also want to think about tumor. All right. I think this is case 3, am I correct?
Yes.
Right.
So we have a mass in the right upper lobe and multiple other smaller opacities in the left upper lobe. So, and maybe I can make out some cystic or like small cavity with like calcifications around it on the right mass.
Yeah, there looks like there's maybe some kind of something around it here.
All right. Okay, so if that's the case, if there's something around that, and this is like okay, so probably we are dealing with a mass in a cavity, and those the other ones I see on the left upper lobe more peripherally, like over projecting over the scapula. Maybe those are also the same process. Maybe some impaction in the bronchiectasis and also, or like mystoma and like a cavity.
Right, like, yeah, fungus ball. Very good. So here's the CT that should help you confirm your diagnosis. Okay. So I flipped this one. This was acquired prone, so I flipped it. So, I left it prone for a reason.
Yeah, so basically you're showing that this is it when prone, it's basically moving
right
around.
Exactly. Yeah. So diagnosis?
So ABPA.
Not ABPA.
Oh, I'm sorry. So somebody who has underlying cavities who develop these stuff in it.
Right. And what do we call these?
Those are mystomas.
Mystomas or aspergillomas usually, yes. Yeah, aspergilloma is probably the more standardized term, but yes, fungus ball, something like that. They're mobile, so it's a saprophytic type. It's not truly an invasive infection, but remember, these can cause life-threatening hemoptysis. They tend to be supplied by systemic arteries, so off the bronchial arteries. So if you're going into interventional radiology, you may be called to embolize these. And in the US, the most common cause of chronic lung cavities is sarcoid, probably true in Canada as well, but in the rest of the world, it's TB. But just any pre-existing condition, cavity can lead to these. And so they're often multiple. Sometimes the smaller ones don't get detected as easily. So yeah, Another clue is you'll see thickening of the tissue around it. These have been here a long time. They don't just show up overnight. So hypertrophy of any extrapleural fat, sometimes you'll see pleural thickening, hyperostosis of the bones. All those findings are signs of chronicity and can also help you with the diagnosis. All right, well, nicely done.
Thank
you. All right, who's next?
Okay, next we have Michael. He's an R4 from Utah.
All right.
Hello.
Hi, Michael.
So this frontal chest radiograph shows a round density in the lateral right lower lung. I think it's fairly non-specific. Could be a parenchymal mass. You know, a lung nodule. Could also be. It looks like there may be an artery supplying it, so it could be an arteriovenous malformation.
Oh, that's smart.
Yeah, good eye. Yeah, and usually what you're seeing is the vein and not the artery, because the arteries are pretty small, whereas the veins can be quite large. So yeah, we do. There's your CT scan. And I have a MIP as well on the next slide.
Okay, so yeah, there's a large prominent vein coming off of the opacity. So I think this is likely an AVM.
Yep. So what can AVMs be associated with?
Osler-Weber-Rondeau hemorrhagic telangiectasia.
Right, hereditary hemorrhagic telangiectasia. And what are some complications of them?
Bleeding, paradoxic emboli causing brain infarct.
Or any peripheral, any systemic arterial infarct, right? So digits, kidney, spleen, also not just bland infarcts, but infections as well. So they can present with brain abscess. Yeah, and about 25% of them have HHT. And when I see one, I look very carefully for other ones because they're multiple in a fair number of patients. And how do you treat these typically?
With angiographic coil embolization.
Right, or some kind of occluder devices, right? They used to resect them, but now you can treat them percutaneously. When reporting these, it's important to identify the number of feeding arteries and draining veins, because sometimes they're complex, to help our colleagues in interventional radiology figure out what they're going after. Good. All right, next case.
So this frontal radiograph shows confluent consolidative bilateral opacities with a basal to apical gradient. I think this could be infectious inflammatory. I think it could be an alveolar process such as alveolar hemorrhage or edema, although I would expect those processes probably to be a little more homogeneous, though I think hemorrhage could look this way.
Yeah, I mean, the problem is you got a bunch of white stuff in the lungs. You don't know anything about this patient, right? I have to give you some history, but if you look, you will notice there's some nodules associated with it. So infection's always a good one because you can have acute or chronic infections, but things like hemorrhage edema aren't going to be hanging around for long periods of time. Let me show you the CT, see if you can figure it out. If not, I can give you some history.
Mm-hmm.
So CT's from the same day.
So, yeah, numerous peribronchovascular nodules with large, predominantly consolidated opacities at the long bases with peripheral ground glass. I'm wondering if this could be angioinvasive aspergillosis.
Yeah, it could be if he were immune compromised and he'd be in big trouble. But yeah, he is. Yeah. So, okay. Anything else sort of on the chronic spectrum? So he's had a cough for 6 months.
Okay. I think this could be cryptogenic organizing pneumonia or eosinophilic pneumonia.
Maybe. And of course, cryptogenic is a clinical diagnosis. So we just say organizing pneumonia. Yeah, maybe it's a little, how do I describe it? Usually it has a little bit cleaner margins than that, but I think that's a reasonable thought. It has these funny bubbly spaces in it too. That can sometimes be helpful. You see, and then here it's more confluent, but you see these little kind of cystic spaces, some airways passing through it. So he's had a cough for 6 months, been losing weight, not feeling well.
Yeah, so cancer, metastatic disease.
Or yeah, primary lung cancer.
Primary lung cancer.
Yeah.
Okay.
And you can always throw in pulmonary lymphoma, but that's pretty rare. Yeah, this is a hard case, and you'd have to set it up properly for an exam, but this is one to be very aware of. So this is a pattern of lung cancer. This used to be one of the old BAC patterns. They called it the pneumonic, like pneumonia. Sometimes it's called alveolar, which is not a good name for it. But it's often a mucinous adenocarcinoma, and it spreads through the airways. So that's how you get bilateral disease, yet no lymphadenopathy. And where the primary is your guess is as good as mine, but it starts and then the tumor spreads to the airways and sets up shop. And so you often get these large masses, but then you get smaller nodules, and they sometimes are kind of have a little ground glass associated with them as it's sort of mucins filling the surrounding tissue. And then over time, they develop these cystic spaces, and they call these bubbly spaces sometimes. And that can be a clue as well. So just be aware that this often gets called pneumonia about 3 or 4 times before someone starts thinking that this is not pneumonia and this is actually cancer. So this is a mucinous adenocarcinoma. So on an exam, they'd have to give you some kind of clue that this is maybe serial images or a history that pointed to a chronic process. But just keep that in mind for chronic consolidation, non-resolving consolidation, adenocarcinoma. All right.
So this person has diffuse bronchiectasis and bronchial wall thickening. I think top of my differential would be cystic fibrosis.
Yeah, that's a great one. It sort of spares the bases a little bit. It's really severe. They're hyperinflated. It looks fairly young person. Sometimes you can sort of gauge by the bones. Yeah, cystic fibrosis. So here's the CT. And just to illustrate my point from earlier, you get a lot of air trapping with cystic fibrosis. And that's the major reason they get obstructive physiology. It's not the bronchiectasis itself. It's the air trapping distal to it. And they get varying degrees of mucus plugging. And it tends to favor the mid and upper lungs. When it gets really advanced, it can be everywhere. But this, for example, this is all air trapping here. You can see there's the lobule. There's the bronchus in the middle there. It's supposed to be tiny, not visible, but it's pretty large. So cystic fibrosis, and there's really no other differential. I mean, you can give a differential of, they can get ABPA, but it looks like cystic fibrosis unless you had the dense mucus that tipped you off. And then usually post-infectious bronchiectasis tends to be more localized to wherever the infection was. So it tends not to be this diffuse. All right. Is that 2 or 3?
That's 3.
Awesome. Well, nice job.
Okay. Thank you.
All right.
Okay, next we have Francis, R4 from Brigham.
All right.
MGH.
Oh, sorry, MGH. They're both
Francis. All right, here's your first case. You get 1 image.
Fat-containing, calcification-containing anterior mediastinal mass. Looks good for a teratoma.
Right. So malignant or benign or can't tell.
Mature, but I wouldn't be confident of that.
Okay, that's a fair answer. So it's a male patient. So 99% of these will harbor some malignant component. Whereas a female patient is the opposite. They're almost always benign and with all mature components. So what's the next step in this patient's management?
Surgical referral.
Yep. Don't biopsy it. Don't waste your money and time on a PET. You don't need an MR. None of that's going to help. It just needs to come out. So my rule for mediastinal masses is if it's not lymphoma or a thyroid goiter that's just hanging out, or some other clearly benign lesion, it just needs to come out. And they're all usually surgical resections, and you don't usually need a biopsy. Versus if it is lymphoma, you don't want to send them to surgery, and then you actually want to get several cores and get the right kind of diagnosis, unless there's an easier site to biopsy. All right. You'll need some history eventually on this one.
Okay. It could be COVID. They're multifocal
Yes.
ground glass opacities, peripherally predominant.
Yeah. It wouldn't be the best COVID case, but you're absolutely right. If I saw this today, I'd call it COVID. All right, but let's say we live in an alternate reality where COVID doesn't exist. So this is a patient that comes into the emergency department, hypoxic, short of breath, and with a fever.
Could be pneumocystis pneumonia.
Yeah, that'd be my first choice. It's pretty much the one and true infection that's extensive ground glass opacity. This one's a bit patchier, and yeah, it sort of looks a little bit like organizing pneumonia, so COVID and influenza, drug reaction, all that other fun stuff. But the hypoxia is a clue, and there's another lab you can check. They shouldn't ask this on the boards, but LDH, yeah, is often elevated with pneumocystis. But I usually just look at the white blood cell count, and sometimes it's really low, and that's a clue, or they're lymphopenic. So this was undiagnosed HIV. So this is pneumocystis. Good. All right.
This is lower lung predominant bronchiectasis and opacities and dextrocardia, Cartaginer syndrome.
Yeah, it's Cartaginer. It's a German name.
Cartaginer.
Don't worry, you're like I spend my career correcting everyone. So poor, he was Austrian, but poor German name gets Frenchified all the time. Yeah, so there's basal predominant bronchiectasis. There's not only is there dextrocardia, there's situs inversus, right? There's a right aortic arch, there's the ascending aorta, and the stomach is here on the right. So it's Cartaginer syndrome. And what are the three components of the syndrome? You got two of them already. There's one more that we didn't show you.
Sinusitis.
Yeah, chronic sinusitis. And it's a problem with the cilia, and it's in that spectrum of immotile cilia syndrome. So about 20 to 25% of patients with that will have the full-blown Cartaginer syndrome. It runs in families. The males are usually infertile, and they have, of course, recurrent infections. There's the CT, but you don't need it. Again, notice the air trapping distal to the bronchiectasis. That's a common sign. Again, that's the obstruction at the small airway level, and this is sort of part of the process. And there's the situs inversus. Good. Oh yeah, look at that. I do have sinus there. In case you didn't get it right away, there it is. Chronic sinusitis, or at least sinusitis, not the best chronic one. All right, well, that was quick. Nicely done.
Okay, next we have Omar, R4 from Maryland.
Hello, Omar.
All right, so we have a frontal and lateral radiographs. The first thing catching on my eye is the right upper lobe opacity. It's kind of showing the appearance of the golden S sign. So we'll be suspecting the right upper lobe collapse.
And what do you think the likely cause is?
A central tumor.
Right. So here on the lateral, you see the displaced oblique fissure. So there's that right upper lobe pancake here. This one's a little unusual. It went more anterior, but you see there's the displaced horizontal fissure, the interfacing here. And most importantly, you've got shift of the mediastinum to the right, diaphragm's up just a touch. The hilum's definitely up a little bit. It's the same level as the left there. So right upper lobe collapse. And there is your centrally obstructing tumor. So if you had to take a stab, you don't know anything about this patient, what is the most likely type of tumor causing this?
Say squamous cell carcinoma.
Yeah, it's hard to tell. If it were a younger non-smoker, you might think of what?
Small cell.
Not small cell. Younger non-smoker.
Carcinoid.
Yeah, carcinoid. But carcinoids don't occur very commonly at this proximal, but they can. So this was a squame. You can get any cell type there, of course, Mets and everything else. And then this extension into the paratracheal lymph node here too. So yeah, and these are considered T3 if they're within a certain closeness to the carina, but that's always arguable because it used to be if it was like 2 centimeters, they set a cutoff and all that. But yeah, obstructing lesions, clearly this is going to be a tough surgical one. All right.
Okay, so we have an axial image with contrast and a coronal minip, and on the axial, it looks like the left PA is coming off the right PA, showing appearance of pulmonary sling.
Mm-hmm.
And the right image, let's see. I'm just trying to. You're trying to show the narrowing, the airway narrowing, or like a complete tracheal rings.
Yeah. Well, there's a narrowed airway, and there's also funny branching of it, right? It looks like there's 2 carinas almost.
Yeah, right.
Yeah, but you answered my other question, complete tracheal rings. Yeah, so there's 2 types of pulmonary slings. The type 1 is typically presents in childhood, where there's associated airway anomalies. So small airways, complete rings, which you almost have to do a virtual bronch to see them very well. They're hard to see on CT, axial, just run-of-the-mill images. But the small lumen should be a clue. And then funny branching. And so this is called a bridging bronchus. So there's the part of there's the upper lobe, there's the middle lobe, and the left lung there. So there's this anomalous airway. And then the type 2 slings are the ones that I mostly see, which are not very often. It's just an isolated finding. More likely to have this on a ped section, but they do sometimes throw ascs in adults. But just be aware of the associated airway anomaly. That's the important thing. And it's always the left coming off the right. Good.
All right. So I'm looking at the image on the right lower corner, and I see this structure is kind of running in the AP, or like between the ascending and descending arch.
This here?
Yeah.
Yeah, it's part of the pulmonary artery. You can ignore that.
I'm not sure. Okay, the great vessels, the branching pattern. Not sure I'm seeing the pathology here.
All right. So when I was studying for the oral boards, we were told it was usually applied to chest radiographs, but it works for CT too. We were told if you couldn't see the abnormality when taking a case, look at 3 structures: the aorta, the airways, and the bones.
Okay. Well, the aorta looks okay.
Yeah, the aorta is fine, and I didn't show you a bone window, so that leaves one thing.
Okay. So there. Oh, I think there is circumferential airway thickening on the probably like the left lower image, which involves the posterior part of the airway. So this could be amyloid or sarcoid or.
Yeah. But it's very focal. That's why I show you these 2 images, right? It's normal here and it's normal at the carina. So at the level of the aortic arch, and then just above it here, I have these out of order. I'm sorry for that, but it's focally thickened all the way around, and then it normalizes again. So yeah, so sarcoid, again, really rare form cause of tracheal thickening. It's usually pretty diffuse. Amyloid can go all the way around for sure. So if you saw this throughout, amyloid would be a great thought. But this is a very localized lesion, and it's a little nodule there. So what's more likely to occur in a localized form?
I mean, it could be a mass, or it could be post-radiation change.
Right. Patient has no history. So this is a 30-year-old, never smoker, presents with kind of a little bit of cough and not a little bit of stridor.
Not sure if carcinoid would look like this.
No, carcinoids in the trachea surprisingly are very, very, I've never seen one. I've never seen a picture of one. And they would present like a typical airway carcinoid as sort of a filling defect. So this is more infiltrative. So think about, so it could be a mass, like a neoplasm. And so what's the most common neoplasm of the trachea?
The squamous cell carcinoma.
Right. But those are usually smokers, older patients. I mean, you see occasional ones, but this guy's 30. So there's one, what's the second most common neoplasm?
That doesn't look nodular. I mean, is it papillomatosis?
No, papillomas are exactly like you said, nodules. They're papillomas, so they protrude in the lumen, and they can turn into squames rarely. But this is infiltrating the wall, so it's growing in the wall of the trachea. So the second most common primary neoplasm of the trachea, it's malignant, is think head and neck.
Oh, adenoid cystic.
Yeah, yeah. So adenoid cystic. So if you see a circumferential thing like this in a younger patient, you want to think adenoid cystic. They can also present as an endoluminal mass, but they have a propensity to grow along the neurovascular bundles, so they can grow along the wall like this. So this is an adenoid cystic carcinoma. You would, you'd have to set up a multiple choice question so that there weren't other things like, but squames are usually a lot uglier, and older patients. Amyloid, as it says, diffuse. Could this be localized GPA? Maybe. I'd expect the lumen to be a lot more narrowed given this degree of thickening. This is more slowly growing, and it's not inflammatory, so it sort of expands out the wall, whereas GPA causes a lot of inflammation and necrosis, so there's often scarring there. Okay, I think that is 3, if I'm correct. If not, I'll go on.
Yeah, that was 3.
Okay.
So next we have Christian, R4 from Utah.
All righty.
Hi, Dr. Kanne.
Hello, Christian.
So I'm looking, it is pleural thickening, circumferential thickening of the left lung and a pleural effusion. I think there's also pleural nodularity inferiorly that does enhance. So I'm concerned about a mesothelioma or not a pleural metastatic disease.
Yeah. What's going to be the most common? If you don't know anything about this patient, what's the most common?
Mesothelioma?
Mets are a lot more common than a mesothelioma. However, there is a finding that makes you think about it. It's very subtle. It's on one image that tells you that this is a mesothelioma, almost certainly.
Yeah, so I'm looking for calcifications. And I think I see them in the middle laterally, the lower row left picture. Yeah.
Let's see. There's one plaque there. It doesn't even have to be calcified. I think that's a vessel maybe, but yeah, there's plaque right here. Good. And there's a plaque here. Yeah, these are pleural plaques. Yeah, this was a mesothelioma, but if you're playing a numbers game, remember metastases are far more common. But yeah, you can really see the nice rind here. Really, it's always a differential diagnosis. And you'd have to worry about a lung cancer that had metastasized. But if you can't find a primary, it's probably a mesothelioma. Good. And they're really rare in the absence of asbestos exposure, but you don't have to have plaques. So they do occur in people who don't have you can't prove they were exposed to asbestos. So don't ever let that sway you. But yeah, the easiest thing to do is do a pleural biopsy. A thoracentesis isn't usually helpful. There is some new immunostaining for it, but it's not perfect. And I think you're better off sticking a needle in the actual soft tissue and getting a piece of that. So maybe right there would be a good target, and then sending that for evaluation. Okay.
So I see those focal consolidations in the right lung, at least 3 of them. They have peripheral ground glass opacities. I'm thinking about angioinvasive fungal infection.
Yep. So usually aspergillus, and you could put any other invasive infection, mucor. Usually mucor gives you a bigger mass. And sometimes nocardia, which is a bacterium, can also look like angioinvasive fungus. So that's one I always put in my differential. It's much less common now, but they do, because patients are often on Bactrim for pneumocystis, and Bactrim, of course, treats nocardia, although the doses they use aren't quite high enough. And then there are some occasional, you can get some bacteria that do this as well. Besides nocardia, there's certain species of Legionella that can mimic this. But if you have to pick one, always pick aspergillus. It's more common. So yeah, that's the CT halo sign. Perfect.
Can Cryptococcus cause that appearance?
I've not seen it with the halo. I mean, it's usually more of just a mass. So if I see big masses, I think of Cryptococcus or nodules, but not one I typically think of with halos. But I usually just say invasive fungal infection, nocardia, and then occasional species of Legionella, and leave it at that and let them sort out which fungus it is.
Okay.
Good.
Thanks.
All right.
Yeah.
Last one.
So I see traction bronchiectasis in the anterior lung, in the middle lobe and the lingula. So that makes me think of Lady Windermere, the MAC. Okay.
Yeah, this is a great look for non-tuberculous mycobacteria. And then just a point of language here. It's not traction bronchiectasis because there's not fibrosis. This is actual primary bronchiectasis. So the airway itself is diseased, but you've got little branching nodules distal to it. You've got some away from it, which I find very important because I think it starts at the level of small airway and the bronchiectasis develops later. So these little clusters of nodules away from bronchiectasis. Now, a point about the Lady Windermere syndrome, I wish people wouldn't teach it anymore because it's flat out wrong, but people like to talk about it. There has nothing, so it's from Lady Windermere's Fan, a play by Oscar Wilde, and the theory is these higher society women wouldn't cough, they'd suppress their cough, and that led to this infection. We now know that's all nonsense, but hopefully they will not put that on the exam, but just be aware that that whole theory has been debunked. There's something immunologic with these patients that they're predisposed to them. And this is called the non-classical pattern in that it doesn't look like classical TB. So if you work at a VA hospital or you have a high population of smokers, male patients who smoke, you're much more likely to see fibrocavitary disease in the upper zones that looks just like TB. Yeah. If you tend to have more non-smokers, it's usually older women, more often white than not. They're more likely to develop this about in their 60s and 70s. And it has a pretty, like you came right to the diagnosis, very pretty typical pattern: anterior, upper lobes, middle lobe, lingula, bronchiectasis. And then again, for clinical purposes, finding those tree and bud, or whatever you want to call them, airway branching nodules away from the bronchiectasis is very suggestive that there's active disease, because I think this is where it starts. So if I'm telling people to BAL, like where to go, I look for where there's a lot of tree and bud, because there's going to be a high yield. So like the middle lobe would be a really high yield out here. Plus it's an easy target to recover this. A lot of times you can just recover it on sputum. All right, I think that is it. Let's see.
I doesn't prefer the anterior lung.
Yeah, it does prefer it, but it's not exclusive, and I don't know why it does that. But again, in some of these males with COPD, it prefers the upper lobes.
Yeah, thank you.
It does what it wants to do. Yeah, and just it's usually MAC in the U.S., but in other parts of the world, there's other species that are actually almost as common. Europe has, it's environmental as well, what's around. So I always just say non-tuberculous mycobacteria, but about 80% of the time it'll be MAC in the U.S.
Thank you.
All right. All right.
Okay, next we have Amina.
All right.
Right, so we have axial and coronal lung window images. And it looks like this is a basilar predominant process with honeycombing. And this I would put at the top of my differential like a UIP process. If there was like a history of smoking, I think like IPF. And yeah.
Okay, well, let's take a look at this a little more closely. So where do honeycomb cysts start to form? Where in the lung?
It stacks, so it's like at the pleural edge.
Right, so they start in the subpleural lung and they start to stack up. Notice these holes, we'll call them holes for now. They're not along the pleural surface here nor here or here. And if you look on the coronal, I gave you the coronal because what is this showing?
So it's kind of like, I guess, linear and branching. So it's probably like an airway.
Yeah, this is really severe traction bronchiectasis with surrounding reticulation and ground glass opacity. Notice the lungs are pretty dense. There's a little bit of crud up here. You can just ignore that. But there's some ground glass out in the periphery of the lung. It's strikingly basal predominant. And so you've got a fibrotic lung disease here. And UIP is basal predominant. It's subpleural predominant. And you like to see honeycombing, but honeycombing, again, is going to be subpleural initially, and it will stack up over time, but it should never spare that subpleural lung.
Okay. I mean, so then I guess if we're still thinking that this is like fibrosis, then NSIP spares, it has subpleural sparing.
Yeah.
And it has like many different causes. I don't see like, you know, esophageal dilatation. So, you know, if I saw that, I would think like scleroderma. But at this point, just NSIP.
Yeah. But I'll tell you, most NSIP, almost all of it, I can't say 100%, but over 95% is associated with connective tissue disease. And so depending on what the underlying diagnosis is, this patient did have scleroderma, but happened to have a decent esophagus. But yeah, if I were writing a question for an exam, I'd pick one with a better esophagus than this one. But I like this case because it illustrates a couple of points. Is people, including practicing radiologists, I see this get referred to us as honeycombing, and a simple coronal or sagittal can set you straight if you're not certain. The subpleural sparing is a relative subpleural sparing, but in this case, the holes aren't stacking along the pleural surface. It's strikingly basal predominant. And this is a decent example of what has been described as a straight edge sign, which it hasn't been studied in depth, but it's a pretty decent sign where there's sort of an abrupt transition of quasi-normal lung, I wouldn't call this normal, to really fibrotic lung. And it's almost a perfect horizontal line. This one's a little less convincing, but there's still a fairly abrupt cutoff. And that's also been associated with connective tissue disease. So when you see NSIP, think connective tissue disease. Importantly, this is not a UIP pattern. It's basal predominant. So we're not thinking sarcoid, we're not thinking HP. So you're kind of left with NSIP. But yeah, there are many causes of it, but almost always it's connective tissue disease. I have seen some COVID patients who go on to fibrose that look like NSIP because that's what organizing pneumonia can do. But if I had to pick one, always go with connective tissue disease. All right.
All right, so on the top, these are all axial images, I guess arterial phase, axial CT, and then MRI, I guess, I don't know, dark blood and bright blood sequences. I don't know.
Okay. Do you remember an MR when you get the little etching along the edges?
Oh, out of phase?
Yeah, so this is in phase and then out of phase. T1, I think. Yeah, that's T1. Fat's nice and bright. And we're in the frequency encoding direction there, I believe. Right? Okay. And then, so this was done for a mediastinal mass.
Okay. Right, so then you see, you do see an anterior mediastinal mass just abutting the sternum, and on the CT it looks mostly homogeneous, and then on the MRI it shows dropout on out of phase, which means that it contains microscopic fat. So in the anterior mediastinum, like a fat containing lesion, I mean, you could get a teratoma. Those I think would look more heterogeneous.
Right, and you should see the fat on those. And they're off midline too. That's the other thing. This is a midline mass.
Yeah. Thyomomas, I don't know if those have fat. I guess
they shouldn't.
Okay.
Yeah.
And then let's see, the other ones, thyroid, unlikely.
Yeah, an ectopic thyroid in the mediastinum is exceedingly rare. I've seen 2 cases ever. It's usually a direct extension. So I don't include thyroid in my differential for mediastinal masses because as a discrete mass, it's just really uncommon. So this is a technique that's been used. This was one of the earlier uses in the chest for chemical shift imaging. So I see this all the time. These poor young patients are told they have a mass in their mediastinum. I know what this is. I see it every day. This is normal thymus here. So this is a technique you can use to prove thymic tissue or thymic hyperplasia sometimes in some patients, is because none of the other masses are going to contain fat that you can't see on a CT. The only one that has fat in it other than like a lipoma or some other rare, like a liposarcoma and some other rare things, is going to be it's just normal thymic tissue. Sometimes it doesn't. Normally you'll see the fat in it, but in this case, it's just it's a female patient. They're more likely to have these trapezoidal shaped thymus, sort of more mass-like, and so that's why this was done. So this is one technique that's been described for this, and just recognize it as thymic hyperplasia for the purposes of the exam, or thymic tissue. And the next step is don't touch it, don't biopsy, don't resect it, don't do a PET, don't do anything. But yeah, yeah, it's the same principle they use in the, or I don't know if they still do in the adrenals, looking for fat in an adenoma. Okay.
Yeah. All right. So axial CT is up the level of the heart, lung window, and there are multiple cavitary lesions.
Well, do you see a hole in any of them?
I guess the one on the image on the left, on the it's in the left lung, I don't know. It looks kind of, yeah, right there.
Well, it's lucent in the center, but it's not a cavity. It's not black, right? It's the same density as lung around it. Kind of like this one and this one. And this one's a little loose in the middle, but it's not black lung. So it's not really a cavity.
Okay, so multifocal, I guess, opacity is then some ground glass, some lucency. Could this be like a lipoid pneumonia?
That's one thought. It's often more consolidative and very irregular. But do you recognize this as a sign that we sometimes talk about, where it has a denser outer rim?
Oh, is that the reverse halo sign?
It is.
So that's, I think, associated with like cryptogenic organizing pneumonia.
Well, just organizing pneumonia. Yeah, cryptogenic is the clinical diagnosis, and it's less common now because we're better at finding out the causes. So most of the time when I see organizing pneumonia, I can tell you exactly what caused it. So if you saw this on call, what's your diagnosis going to be? If you were on call tomorrow, what would you say this is? Like, what's the cause of this?
I'm not sure.
COVID. You would say this was COVID.
Oh, okay.
Now, in normal times, or as in the before times, before we had COVID, this was likely to be a drug reaction. It still is. And so if you're still doing, I mean, we're still imaging all our immunotherapy patients, oncology patients. So drug reactions always in the differential. Connective tissue disease. So this is a pattern. This is organizing pneumonia. These are reversed halo or atoll signs. It doesn't have to be cryptogenic. And as a matter of fact, it rarely is anymore, because a lot of what was early cryptogenic organizing pneumonia was undiagnosed influenza, undiagnosed drug reactions, connective tissue disease that later declared itself. So just say organizing pneumonia in your impression and on an exam. It's only cryptogenic if there's no identifiable cause. But some of these patients will have myositis, and they present like this. So it's the one connective tissue disease where lung involvement may present before the muscle involvement becomes clinically apparent, or it's subtle. So patients may just think they're getting older. They're actually weaker. And people don't, in an emergency department or a busy clinic, they may not do a very detailed neurologic muscular exam where they have them standing up and reaching overhead and doing all this kind of stuff. So yeah. So reversed halo signs. It's also been reported with vasculitis as a manifestation, and I mentioned drugs and infections, but it's usually flu, and now it's COVID. So if you see this pattern now, it's COVID, and as long as this pandemic's going on, just based on prevalence. So it depends on where you're at. But okay, I think that's 3. Is that correct?
Mm-hmm. Yes.
All right. Well, nicely done.
Thank you.
All right. Who is our next participant?
Next we have April R4 from Utah.
Hi, Dr. Kane.
Hi, April.
So we are looking at lung and soft tissue window axial CT through the chest with contrast. We have a large mass in the right lung that is pretty central. It does look like maybe there's some fat density in this.
Yep.
And then on the left-hand side, there is kind of a similar process that's happening dependently. So I'm wondering if this is like a lipoid aspiration, lipoid pneumonia picture.
That's what it is. There's really no differential. Perfect. Excellent.
Okay. So this axial and coronal view of the chest, I think this is pretty florid honeycombing. This would be the UIP pattern.
Right. So it's subpleural, basal predominant. This is honeycombing. See, it starts at the subpleural lung and stacks up there, right? And then the central lung is relatively normal, and that's an important finding. NSIP tends to be a lot more diffuse. You have a lot more ground glass. If you remember that other case, I showed it crept all the way up. It was even more basal predominant. Now, this patient probably has a little bit of emphysema. So, you know, most UIP is idiopathic, and about 2/3 or so of those patients are smokers, maybe up to 3/4. So it's not uncommon to see some emphysema, but that's what I look for. When I see fibrosis that's really peripheral and the central lung is relatively clear or uninvolved, that really points to UIP. And if you have the honeycombing and everything else, all is good. So what are some other causes of UIP besides the idiopathic form, which is the most common?
Yeah, I think you can get it with RA.
Yeah.
And that would be the two that I can think of off the top of my head.
And that's going to cover 95% of them. It has been described, I've seen it with other connective tissue diseases, but a much less common. There's familial fibrosis. I've seen it as the end stage of a drug reaction, but less likely than NSIP. And asbestos. So asbestosis is fibrosis from asbestos. So if you have pleural plaques, the presumption is it's asbestosis, even though if you look at sort of social histories, more likely than not, someone who's been exposed to a lot of asbestos is likely to have had a tobacco history just because of socioeconomics. Not always. So if you see plaques, the presumption is it's asbestosis, even though it's still a UIP pattern. And there's a few other things, but yeah, RA and idiopathic are the big two. Okay.
Okay, so a frontal and lateral chest x-ray, I think we see flattening of the diaphragms bilaterally and kind of lucency. My cat is saying hello. Lucency of the lung apices. This looks like emphysema to me. I think it's very hyperexpanded. I'm wondering, I think there's lucency in the apices. I'm also wondering if there's lucency posteriorly and dependently, or if I'm just getting faked out.
Well, look at the vessels. That can be a big clue. You're right. You're all over this case, but I think you're going to come to a conclusion very quickly. Look at the caliber of the vessels in the different zones of the lungs.
Yeah, I think they taper kind of everywhere. So I would be worried that this maybe is a pan-acinar emphysema.
Okay.
Like an alpha-1 antitrypsin. Although yeah.
Yep.
Okay. So we have multiple axial slices and a coronal slice, and it's definitely basilar predominant. I was overestimating what was happening in the apex. So alpha-1 antitrypsin deficiency.
Yeah, so panlobular is now the preferred term, but I knew what you meant. Anybody will do. And the reason they call it panlobular instead of panacinar is it not only does it involve the entire acinus when it's there, it involves the entire lobule, and more often like most of a big lobe. But this is classic alpha-1, basal predominant panlobular emphysema. There's sometimes, in this case, we have mild central lobular emphysema. Even if they don't smoke, they can get emphysema, but if they do smoke, they get it at an earlier age and it's more severe. Back to the radiograph. Yeah, so it looks loosened up there, but remember, now that these are all digitally acquired, the computer is trying to make this look like a chest, so it has to compensate for lucencies here. And there's some overlying chest wall soft tissue that makes it look denser, but if you look, there's absolutely hardly any vessels. They're just little threads, whereas the vessels up here are a lot juicier, and of course, that's the opposite of normal. And when we talk about flattening of the diaphragm, I always point out it's on the lateral. This is one of the few times where it's actually on the frontal too, and you can see the different slips. This, I think, takes the prize for flattening diaphragms, and then that hyperexpanded chest. So alpha-1, there is one other thing that can do this that was a big deal in the 90s and early 2000s. Some of you who live on the West Coast might still see some of these people around.
I don't know it. I
Okay.
assume some sort of drug, but I don't know.
Yeah, they used to inject Ritalin. They used to crush up the Ritalin tablets because it's speed. And of course, they were like extended release and then inject them so they get a rapid amphetamine high. So when I was in training in Seattle, these people would roll into our emergency department and they looked like Alpha 1, but then you realize they were like 30 years old. And they were some of the carryovers from the 90s when this was a big deal. Now there's other stuff, but yeah, injectable drugs sometimes can cause a panlobular emphysema too. Sometimes you'll get nodules as well. So like people crushing up OxyContin and stuff, but it knocks out the vasculature as well. So excipient lung disease sometimes looks like this, but for purposes of the exam and just commonly in the world, you're going to go with Alpha 1. All right, I think that's 3. That was nicely done.
Thank you.
All right, who's next?
Okay, next we have Leigh from Oklahoma.
All right.
Hi, Dr. Kane.
Hello.
So we have an axial and coronal CT views of the chest that show what looks to me as diffuse ground glass central lobular opacities. Looking at the airways, I don't see anything unusual. Any history with the patient, or?
Oh, well, we'll get there.
Okay.
So there's a pretty limited differential diagnosis for this.
Ooh. Okay, I'm gonna start with infection. Well, let me think.
Have you ever seen an infection involve every single small airway in the lung like this?
No, not really.
Not really. Usually, and it's usually tree and bud, right? It's usually not fuzzy nodules.
That's right. Yeah. Okay. So, am I thinking of a miliary pattern here?
Well, they're not miliary. No, you were right.
No.
These are central lobular
Okay.
nodules. So they're centered on the small airway. They're poorly defined, so they're ground glass attenuation, and they're diffuse. So there's really 2 things, really 1 thing. So this patient has a cough. It doesn't help you much, but.
Okay. Let me think. This. I want to say it's. Is it eosinophilic
Nope.
pneumonia?
No.
Hypersensitivity pneumonia?
Yes, yes.
Okay.
Pretty much an Ant Mini for hypersensitivity pneumonitis, not the fibrotic form, but the active form.
Okay.
Yeah. So these patients will be symptomatic, pretty strong. Like they'll have fevers, weight loss occasionally, but definitely a temporal relationship with their symptoms. So these aren't people who've had symptoms progressing slowly for 20 years. They either got exposed in the last 6 to 8 weeks, or they've had a bird for maybe a few months, but not years and years and years. The main differential is if this patient were a smoker, in which case, what might you consider?
If this patient was a smoker, I would consider RB-ILD.
Or just RB, or respiratory bronchiolitis. Yeah, ILD portion is clinical diagnosis, but I've never seen RB involve the entirety of both lungs. It's just, it doesn't happen. It tends to involve just the upper lobes, and it's usually a lot fuzzier than this. So if you see diffuse central lobular ground glass nodules in your exam or in the real world, it's probably HP.
Okay.
Yeah, that's really it. There's nothing, I mean, there's a few rare things like with vascular disease, but those are patients with long-standing pulmonary hypertension. I'm not even going to get into that. You can watch that on the webinar sometime. We talk about it a lot.
Okay.
All right, next case.
Okay, AP and lateral chest
The
X-rays.
PA. So
PA.
a tip I always tell my residents and the medical students is if you're not on a frontal, if you're not sure, just say frontal. I mean, you're taking a written exam, but when we took the oral, you didn't want to be wrong. So you just said frontal because you technically were right. And hopefully they wouldn't push you on it. It's a PA.
Cool. Okay. Frontal or PA, chest X-ray and lateral. I think there is a little bit of interstitial thickening, and it's more central.
Yeah, so the interstitium is fine. So this is an older radiograph, but if you look at the vessels, they're actually very well defined. There's some grid line artifact maybe you're seeing. So we'll let that go. Another clue is the diaphragms are still pretty sharp and the heart borders are sharp. And when you get some subtle changes in the lung, usually the interfaces start to go. So we'll let the lungs go for now.
Okay. So the lungs are okay. Let me look at the bones. They look okay. The soft tissues. Okay, is it a right side of the aortic arch?
It is a right aortic arch. Very good.
Okay.
Yeah. So there's a right paratracheal mass here. There's no left paratracheal. Airways displaced slightly to the left. And on the lateral, sometimes you can catch an indentation. So what are the two main flavors of right aortic arch?
You can get mirror image branching or conventional branching.
Well, the conventional is the mirror image.
Oh,
yeah, it's just flipped, but yeah.
I forget what's the other one.
So the other one is an aberrant left subclavian.
Oh, yeah.
Which one would you rather have?
I would rather have the aberrant right subclavian, right?
And why is that?
Because the other one is associated with more cardiac anomalies.
Exactly. Perfect. Yeah. So here's a right aortic arch, aberrant left subclavian artery. Sometimes it comes off a diverticulum. That diverticulum has a name.
Yeah, it's the diverticulum of Comro.
Interestingly, in Commerell's paper, it was all left aortic arches, not right aortic arches. The name stuck. And the reason you get that diverticulum is the ligamentum arteriosum tends to stay on the left, regardless of the arch. So there's a tethering of the aorta. And as the patient grows and the aorta moves up and gets bigger, there's sort of an anchor. And that's the thought that it sort of creates this diverticulum. So yeah, so this is in effect a ring, but it's a loose ring. So it's very, very rare to have ring symptoms from this. These are just normal variants. They occur in about 1 in 1,000. About 10% of these patients will have congenital heart disease. Now, granted, in an adult population, it's lower because we image more patients, and we're now talking adulthood. So when I see these, they're almost just incidental findings. Mirror image branching has a much higher rate of congenital heart disease. It's usually cyanotic. So tetralogy of Fallot is the most common, and it's about 10% of TETs. And about 20% of truncus will have a right aortic arch with or right aortic arch with mirror image branching. But remember, truncus is so much more rare than TET. So if you see mirror image branching, think about tetralogy of Fallot. That's just going to be the most common. All right.
Okay. You're showing me axial and coronal CT images in the soft tissue window. Seeing like diffuse, it's a non-contrast CT, so I'm seeing some diffuse soft tissue density surrounding the trachea and the upper mediastinum.
Yes, I just want you to focus on the trachea here.
Okay, so the trachea looks like there is circumferential involvement, and it looks focal in the coronals. Is this
That's
like post-intubation stenosis?
Yep, exactly. Perfect. Yeah, this is the classic hourglass appearance. It occurs right at this level. So here's the catching some of the thyroid cartilage. So it's just right about the level of just above the thoracic inlet. So the clavicles are, if we went down a little lower, we'd be at the manubrium. This is classic location. We don't see a lot of this anymore. More often you see it in patients who's had a tracheostomy, but it's from, because they use all low pressure cuffs now, but it does still, you still might see it in there. So yeah, exactly. All right. Is that 2 or 3? I'm sorry, I'm not keeping track.
I think this is 3.
Okay. Well, you did a great job, Leif.
Thank you.
All right.
Yeah, that was 3. And I'm not sure how we're doing for time,
We've
but
got 4 more minutes according to my clock.
yeah. So I guess we have time for one more, maybe round.
Sure.
Okay. So next we'll have Aaron from Brigham.
Hi. So we're looking at frontal and lateral radiographs of the chest. Interesting. I mean, the lung parenchyma, I feel like I see like a bunch of kind of like subtle articular opacities. Am I seeing a lucical sign kind of like in the left upper chest there? Are
Right
you showing
here?
lobe collapse? Yeah.
Yeah. Okay, what else do you see?
And is there kind of like traction on the left diaphragm, kind of like pulling
a juxtaphrenic peak. Okay.
And the trachea is kind of pushed to the right. So I guess that would make me suspect some sort of like obstructing mass.
Yeah, causing what?
Causing left upper lobe.
Yep, left upper lobe collapse. That's what I wanted you to say.
Okay.
Yeah. So here it is on the lateral, right? There's the oblique fissure displaced. There's the collapsed lobe. Yeah, there's a haziness here. So that's the en face left upper lobe. You mentioned the Lufsickle sign, which is right there. You got a distorted hilum, narrowing of the airway, a juxtaphrenic peak. Notice the left lung looks smaller than normal. The right heart borders shifted just a little bit. And there is some mass effect in the region of the AP window. Makes you wonder if there's a mass there. So there you go. So we've already been through the differential diagnosis. This was another lung cancer. I think it was another squame, but could be a carcinoid too. That's another possibility. They're often hypervascular, so that could be a clue. And there's the obstructed left upper lobe. So yeah, so you saw a right upper lobe and a left upper lobe, and there's a MET right there just for fun. And one down here too. All right.
Okay, so again, we're looking at frontal and lateral radiographs. I mean, the most striking abnormality is kind of like along the right posterior pleura. There seems to be some sort of large opacity. It looks like it's, arising from the pleura, or at least outside the lung parenchyma.
Yeah, it's very broad-based, and it's got a very smooth interface, which favors it being non-lung.
So, I mean, I would like to see cross-sectional imaging, but I guess something like a solitary fibrous tumor of the pleura would be on my differential. So we're seeing kind of like a soft tissue density mass attached to the posterior right pleura. I'm still going to go with solitary fibrous tumor.
That's about all this can be. I mean, there's not too many pleural tumors. Yeah, and they're pretty dense usually. They can, as they get bigger, they become more heterogeneous. You'll see calcium, sometimes necrosis, sometimes vessels in them, but they're often sort of elongated like this, and sometimes you'll see them on a pedicle. They can flip around. But this is a solitary fibrous tumor of the pleura, and you just resect them.
Can I ask a really quick question? I kind of struggle with differentiating these from like a nerve sheath tumor.
Well, here you can see there's a fat plane right there.
Okay.
So that would tell you, you can see the extrapleural fat. So that tells you, it's just like you distinguish a hemothorax from an extrapleural hematoma. You can usually see the mediastinal fat, the extrapleural fat between it and the rib, and that's usually a helpful finding. Also, they tend to be more homogeneous than a nerve sheath tumor and blobbier. This one's more elongated, but yeah, I mean, these things to do is just core it, put a needle in it, and you know what it is. But okay, all right.
Okay, so again, a frontal and lateral chest radiograph. I see some fullness kind of in the right hyla, probably the bilateral hyla.
Yeah, you got an extra bump out here.
Yeah, and then I guess on the lateral, I like struggle with this all the time. I feel like some people talk about like the donut sign. I feel like that's what I'm seeing there.
I'm still waiting to see one actually look like a donut. It usually looks like a squash donut that someone's already taken a couple bites out of. But yeah, the infrahilar window is filled in. This area right in here, there's a little triangle of just that it forms from the overlapping structures, and there shouldn't be anything in it. And you see there's this mass right here. So there's the airway, right pulmonary arteries right about here. The left is crossing behind. This is rotating a little bit, but there's too much in that infrahilar window, and that's where you want to look. And then also even the posterior wall of bronchus intermedius, there's too much tissue. So yeah, there's bilateral hilar lymphadenopathy. It looks a little thick up in here, although the azygos is there, so that's tough, and maybe a little bump up in here. Hard to say because the aorta is right there. So what do you think?
So if I were seeing like more right paratracheal, I would lean on sarcoid, but something like this, I would put like lymphoma on the differential.
You know, it turns out that getting lymphoma in this distribution is really not a thing you see. If you think about all the lymphomas we see in the mediastinum, they're usually either in the prevascular space or they're sort of everywhere. And it's unusual just to get bilateral hilar lymphadenopathy. So I would still go with sarcoid. You can get METs from pelvic tumors. So in a young male like this, you would think of testicular. That would definitely be in my differential. Maybe a renal cell. We do see them in younger patients. Those are the two I might think about. But here's the CT scan.
Okay. Is there anything here to add?
Not really. It just confirms what you know.
Okay, yeah. So
but it shows it subcarinal node 2, and it's very homogeneous. So sarcoid.
Okay.
Yeah, sarcoid's common. And these patients usually have no symptoms when they're like this. I mean, they can, but a lot of times it's an incidental finding. And this is the so-called stage 1 where you have just lymphadenopathy. So stage 0 is normal. Stage 1 is lymphadenopathy. Stage 2 is lymphadenopathy plus lung disease. Stage 3 is just lung disease. And stage 4 is fibrosis. Now that was based on radiographs. We don't use it too much anymore, but it does correlate sort of with prognosis. So patients like this, typically they don't, if they're asymptomatic, our pulmonologist won't even treat them. It'll kind of go into remission on their own, on its own. But if they have lung involvement, they're more likely to give them steroids. And they're more likely to progress if they have more lung involvement, but they can also respond. All right, I think that is 3. So I have more if we have time. If not, we can just take, if you have any last minute questions. Everyone did really well.
Yeah, we had just a couple of questions in the chat because I guess we'll stop here as far as cases go. Somebody asked, let's see, where was it? How do we differentiate the focal tracheal stenosis from focal stenosis secondary to a primary or prior intubation? This was the case.
Oh, yes, yes. So, I mean, you can get subglottic stenosis in patients with GPA, but it's going to be right below the cords. With intubation stenosis, it's classically right at the thoracic inlet and has that hourglass configuration. Hopefully you have history, and sometimes you don't. But remember, GPAs are fairly rare disease compared to people getting intubated. But yeah, sometimes you can't tell. But most of the time, based on the location.
And then just one other question, the best way to differentiate the tracheobronchopathia from
TBO, yes.
TBO from relapsing polychondritis.
Yes. Okay, so relapsing polychondritis is going to be diffuse, and it's going to be smooth thickening of the cartilaginous portion of the airway. TBO are little hyperplastic nodules in the submucosa, and they're going to be patchy. They can get quite large, rarely, and protrude into the lumen somewhat or push into the lumen, and they're going to be chunky nodules. But like I said, clinically significant disease is case report level, whereas relapsing polychondritis is a progressive disease. So if it's smooth and it's diffuse, go with RPC. You'll never see if they put TBO on exam, I'd be pretty disappointed because it's not something you should be testing on since most people can't even say it. And it's just so rare. Like I said, I've seen one case ever that protruded into the lumen enough to cause symptoms, but nodular versus smooth.
Okay. It looks like people want to keep taking cases.
I still have some cases. I got time. That's fine.
Okay, great.
Let me just share my screen again.
Okay, so next up was me. I was trying to not take cases.
All right, let's see what you get. There you go.
Okay, let's see here. Okay, so we've got some axial CT images. We've got a rounded opacity in the right lower lobe. There's a small pleural effusion, and then leading to that rounded opacity, we have sort of some swirling of the parenchyma. So this is a round pneumonia.
Not pneumonia.
Oh, I'm sorry, round atelectasis.
Yeah, you were getting there.
Those peds, yeah.
This is round atelectasis. And you'll notice not only is there an effusion, there's pleural thickening. You can see it, this little rind there. And it actually is bilateral. It's just early on the left. It's not quite rounding yet, but it's semicircling. But yeah, this is classic rounded atelectasis. And the important thing to remember is you have to have pleural thickening next to it. If you don't, you can't call it rounded atelectasis. And then you have to worry about a mass pulling in the lung. But in this case, I'm pretty confident. And when do you let it go? I typically let it go. Most of the time you'll find old imaging. The most common cause I see is people have had heart surgery because it's far more common than asbestos, and they have chest drains in, they get blood in there. So you'll see it they'll have sternal wires as a clue, or they've had trauma. That's another clue. But usually, or an old empyema, something like that causes pleural thickening. All right, good. Let's see.
Okay. What we just talked about. So we have an axial and coronal images through the chest. The pathologies at the trachea. We have thickening. I think circumferential thickening of the trachea.
Yep.
So it's involving the posterior wall. There's no calcification.
Oh, there's a fair amount of calcium.
Oh, sorry. Oh, yeah, that's calcification.
And it's diffuse, right? And it's kind of lumpy bumpy.
Mm-hmm. This one, is this the TBO?
No, remember that's submucosal nodules. I wouldn't show TBO because I don't think it's appropriate for a board review, but that's, yeah.
Then I think about Wagner's.
Yeah, GPA is much patchier and it doesn't usually cause this much thickening, and it causes a lot more stenosis. Remember, it's a necrotizing vasculitis, so it causes a lot of scar tissue. And so you'll get stenoses, occlusions. It's unusual to get this much thickening, and it doesn't calcify usually because it's just such a destructive process.
Okay.
So this is almost pathognomonic, this appearance, so there's only two things I think about usually that are diffuse. So we talked about RPC because it doesn't spare anything, but it spares the posterior membrane, but it tends to go all the way down and out. This is circumferential and goes all the way down and out as far as I showed you. So there's another cause of tracheal disease that can do this.
It's amyloid.
This is amyloid. Yeah, there's really nothing else that looks like this. There's some rare causes. I've seen a case of pemphigus, a case of rhinoscleroma, which we just don't see in the U.S. really anymore at all. I mean, it's from people from tropical regions, so they'd have to immigrate to the United States to see it. It's just a rare disease. So if you see something diffuse like that's kind of lumpy, bumpy like this with calcium, think of amyloid. All right.
Okay, so we have, let's see, frontal and lateral views of the chest. And let's see.
The radiograph may be a bit tough. I'll go to the CT if we need to.
Okay.
Don't fret.
Yeah, it kind of became a little bit fuzzier all of a sudden, not to make excuses. I think there's some abnormal opacity in the maybe like left lower lobe.
Yeah, there's something down here.
Yeah.
And if you look carefully on the lateral, it looks a little funny here and down here. And there's some stuff up here too.
Okay.
All right. And then maybe something here. Let's go to the CT. And I have some soft tissue windows as well.
Okay. Okay, so for this, we have some areas of central bronchiectasis. In the left upper lobe, we have this, I think it's like the finger and glove finding near the apex.
Yeah, you have a branching structure that's filled with something. And we know we have bronchiectasis elsewhere, right? So the presumption is this is probably an airway.
Right.
Okay.
So let's see.
And there's one here and some down here. So let me show you the soft tissue windows.
Okay. I'm thinking of ABPA.
Yeah, and what's making you think about that?
The bronchiectasis and the mucus plugging.
Mm-hmm. And why did I show you the soft tissue windows?
To show that those are not vessels. They're
okay. Well, this is a non-contrast, so it doesn't really
help. It doesn't help.
But it does help because it does show you something. This right here may help you the most.
Okay.
What do you think about the stuff in the airways?
I mean, it's soft tissue density.
Yeah, compare it to blood pool.
Right.
I know these are the noisy, sharpened images, but still you can see the attenuation is different.
Mm-hmm. So kind of shows us that it's mucus plugging.
Yeah, but mucus is usually water attenuation, right?
Oh, right. Yeah.
This is really dense. So you have the right diagnosis, but this is an important finding because this is pathognomonic for ABPA, this hyperdense mucus plugging. So the Aspergillus organisms contain some metal ions, iron and manganese in particular, probably magnesium as well. And between that and the mucus in there, because mucus plugs are usually low attenuation. That's one of the ways we can say, oh, it's just mucus and not a tumor. But when you see dense mucus plugs, especially this more central bronchiectasis, these larger airways like this, when I see this is ABPA. It's pretty simple. So good. Yeah. So yeah, the so-called finger and glove, if we go back to the radiograph, you can sort of make out some branching. It's really hard. I don't have any really great cases with good radiographs. A lot of times they just have CT, but yeah, always look at those mucus plugs and soft tissue windows, and it can help you. And you can just make a very confident diagnosis of this. All right. That's 3, I think.
Yes.
Okay. I have a few. I don't know how many more cases I have. We'll just go till I run out.
Okay. So next we have Swachanda. He's an R3 from St. Vincent.
All right.
On, or maybe not.
Hi, Doc. Yeah, I'm here.
Hey, how are you?
Good. How are you, sir? Doc?
Doing well. All right. So this is an anatomy question for you.
Yeah, looks like there is an the right upper lobe bronchus is coming probably just above the carina, so probably pig bronchus or bronchus suis.
Yeah, so it is a tracheal bronchus, but this is actually supplying the apical segment. This is supplying the anterior and posterior segment. So turns out in humans, most of the time, it's just the apical segment that comes off. So I don't let my residents call them pig bronchi. If you look at CT scans of pigs, actually the entire right upper lobe is supplied. That happens sometimes in humans. So if I were writing a question, we would probably use the term tracheal bronchus. Yeah, be aware, this is one of the variants to be aware of, is the tracheal bronchus. The other is the cardiac bronchus, which will occur as usually a blind ending outpouching right about here at the bronchus intermedius. Sometimes it has its own tiny little lobette. But tracheal bronchus, just a good anatomy question. Okay?
Yeah. In this axial and coronal CT, mediastinal window, so I can see there is a lobulated, likely enhancing lesion in the exactly at the carina. So I would be concerned about some. Doesn't look like a secretion or any foreign body, because I think it is broad base with the adjacent wall. So I would be suspicious for neoplasm.
Yeah, and what's the most likely neoplasm?
Squamous cell.
Yes, exactly. This is a squamous cell. So most squamous cells of the trachea look like this. They're polypoid lesions. Another clue that it's a mass and not just a foreign body is notice the wall is a little thickened here. There's probably some tumor ingrowth into the wall. Yeah, so squamous cell carcinoma of the trachea. All right.
The frontal and lateral chest radiograph, I think I can see a round opacity in the right lower lung, and on the lateral radiograph that is superimposed over the heart, so looks like it is within the lung.
Yeah, which lobe?
It should be the middle lobe.
Yeah, it's a middle lobe, right, because it's anterior. Okay, so yeah, there's a well-circumscribed lesion there. What do you want next?
CT?
Yeah, the differential's too long to go through.
Okay, so yeah, we see the calcified.
And this is calcium, not contrast, I should clarify.
Yeah, popcorn calcified lesion in this area, so hamartoma.
Yes, kind of looks like the little Discord guy, doesn't it?
Yeah.
Yeah, so this is a hamartoma. So no need to biopsy it, no need to do a PET CT, no need to do anything with it. They do grow. They grow very slowly. So depending on how old the patient is and how big it is, there may be a discussion about wedging it out just because they can become a problem, but very rare to need to take these out. All right, Swachanda, nice job on all 3 of those.
Thank you, Dad.
All right, this may be the last case, if I remember correctly.
Okay, next we have Dustin. He's R4 from Alabama.
We've got an axial and coronal lung window, CT showing, I think, lymphatic nodules with an upper lobe predominance. I think this can be like a pneumoconiosis or sarcoid.
Yeah, this is pretty classic perilymphatic pattern. And sarcoid, of course, is more common. Now, unlike that case of silicosis I showed early on in the session, notice these nodules are more irregular, and that tends to be what you see with sarcoid versus silica. They tend to be, and coal, they tend to be a little rounded. But I want to, again, just reinforce the point. When you see nodules clustering together like this, that's great for perilymphatic. This one's pretty easy because you can see them studying the fissures, and you see them along the costal pleura, but these larger clumps are very characteristic. Yeah, and the distribution is pretty classic. So this is a textbook case of sarcoid. And just remember, sarcoid is more common than all the pneumoconioses. And so we're talking silica, coal, and beryllium disease. All three of those can look exactly like sarcoid. And berylliosis can actually present with just lymphadenopathy. It's there's not too many beryllium mines, but you can see it in manufacturing. So you really need a good history to be specific. But if in general practice you see something like this, it's going to be sarcoid. And no, I have more. All right, we'll keep going. I lost count.
We've got two axial non-contrast CT. Kind of like a lobulated mass, kind of pretty space. There might be like there's a little calcium in there. And I think there's also
punctate calcification.
So I think I would say like a seminoma, since it's sort of lobulated.
Well, what's more common though?
Like a teratoma.
But more common than any germ cell tumor. Germ cell tumors are fairly rare. What's the most common mass in the prevascular space? All comers.
Thymus.
Yeah, so thymomas about, so 2/3 of mediastinal masses occur in the prevascular space, and at least half of them are thymic epithelial tumors. Yeah, so this is pretty classic for thymoma. And they tend to be lobulated like this. They tend to be pretty dense. They may have calcium, about 20% will have some degree of calcification, and they tend to have sort of these little lobulations that can help you. Lymphomas are a lot smoother, sort of infiltrative. And then germ cell tumors, even the not like seminomas, they tend to have a lot of necrosis in them and be locally aggressive, but they're just so rare relative to thymic neoplasms. I didn't give you an age, but thymomas increase in incidence till about the age of 60, and then they start tapering off. So in kids, they're pretty rare. They're very rare in young adults. I do see them. I mean, we took a thymoma out of a 30-something-year-old last week, but that's an uncommon thing. Most patients are 50 or 60. All right, and this one, I've got a set of images for you. So here's the radiograph. You may not even need the CT.
I don't know.
It's worth, I always get a shot.
Well, there's bilateral lower, well, really there's like right middle lobe volume loss, and there's like some lucencies.
Yeah, tell me about those lucencies.
It almost looks like Chilaiditi syndrome.
Yeah, so it looks like bowel, right?
Where the colon goes in front of the liver.
Right. But you don't really see a good diaphragm, do you?
No.
So what else could it be?
A middle lobe mass with some cavities.
Okay. I have some sagittals as well.
So I think we're just seeing a very high right diaphragm here.
Okay.
With actually, I think it's the diaphragmatic rupture.
So where's the defect?
Anteriorly.
It's right here, right? So you have colon sneaking up here with a bunch of fat around it. So it's anterior, and we're fairly, we're not too far off midline, so we're medial. Notice the diaphragm is here, and you see it posteriorly there, but you don't see it anteriorly. And then out laterally, there's a little bit of diaphragm there. So it could be an old rupture, but we don't see any signs of trauma, and this is a PA and lateral, so I doubt this was a acute trauma patient, and we don't see any old fractures. So what else could this be besides a traumatic rupture of the diaphragm?
It could be like a Morgagni hernia.
That's exactly what it'd be. It's Morgagni hernia. Yeah, so they're anterior, they're medial, and it's usually colon. So that's what this is. Yeah, the radiograph's hard because you're right. You could have an elevated diaphragm and you just have some colon. But clearly you recognize these up there. And you see the colon coming up. But when they're this big, sometimes it looks like an elevated diaphragm. That's why you really need the CT. And what's fooling you here is this is atelectasis and not the diaphragm itself. And that's the edge of the hernia itself. All right. I think that's 3. So I should have another case. Yeah, whoever's next.
Okay, so next we'll have, we'll go back to Grace.
Hey, I'm back. Okay, right. Sorry about that. That was slightly obnoxious. Okay, all right, so we have a frontal chest radiograph and we see an opacity in the right upper lung with a kind of like a fissure going through. So I'm wondering if this is just an azygous lobe.
Yeah, azygous fissure. There's no actual lobe. I know it gets called that, but there's no lobe. It's just, that's an azygous fissure. Yeah. So that happens to be another congenital thing, but there's one other thing on this radiograph that's abnormal that I'm more interested in.
Ooh, I see it. So there is a tubular opacity in the right lower lobe. So I think there's partial anomalous partial anomalous pulmonary venous drainage.
Yeah, and where do you think this is going?
It looks like it's probably going to the intrahepatic IVC.
Yeah. So do we have a name for this appearance?
Probably a Smith-Tarr syndrome.
Oh yeah, one of my favorite.
Yeah, I like it too, and you see that it's cool. It's a cool syndrome. Okay, so here is an MRI of the heart, and we can see a bunch of axial slices, and I see that you also are giving me a thing of the liver. This is the same case. I originally was thinking that it's a different case.
No, it's the same one.
It's the same one, and we can see that there's this partial anomalous pulmonary drainage going to the intrahepatic IVC there.
Yep. And there's the scimitar vein. So what are the main components of a scimitar syndrome?
Okay, so we have a right-sided pulmonary anomalous pulmonary vein drainage.
Yeah, you have to have that. That's the main thing. And there's 2 other things associated.
And generally, we also have hypoplasia of the contralateral lung.
Yeah, and the right lung's a little small.
It's a little smaller, yeah. And then the third thing is honestly not coming to me right now.
It's usually shift of the mediastinum, which we don't really have.
Gotcha.
A great example. But there's a lot of other things that are commonly seen. The branching pattern of the right lung is usually very strange. You can be missing segments, lobes. You can have systemic arterial supply. You can have diaphragmatic defects. And then you can think of anything else congenital. The azygous fissure probably has no relationship. What's kind of cool about scimitar, though, is we've collected, I want to say about 25 of them on our webinar over the last 11 or 12 years. And I've yet to find any 2 scimitars that look exactly the same. There's always some different congenital anomalies. I even have a couple with 2 scimitar veins, and some patients will have no right pulmonary veins. So the entire lung will drain into the scimitar vein. And those patients have a fairly sizable shunt, so they may need to be repaired. Whereas if you still have normal veins, this may just be an incidental finding that doesn't require any further workup. Yeah.
For those patients with their entire lung drained, do they generally have worse prognosis?
I'm sorry, they have what?
Do they have generally worse prognosis? Like
not necessarily. They just may need a surgical repair because you imagine it's about almost a 50% shunt. Whereas if it's just partial, it may be a 20-25%, in which case they don't touch it. But I've seen them repair a few scimitar veins just because they're overloading their right heart. The ones that have a bad prognosis usually have like congenital heart disease, but in today's world, that's all picked up in infancy. It's not like we don't have a ton of patients walking around with atrial septal defects unless they just don't have access to healthcare.
Okay.
All right.
Okay, so we have an axial CT chest. Looks like we're in the lung windows, and we also have a coronal CT chest. And the first thing that catches my eye is just in the left lingula, there's all this interstitial septal thickening. I wonder if it's like we're not really seeing it very in other lobes. It's mostly just in that left lingula. So I'm wondering also if there's a little bit of nodularity along that
There's some nodules. Yeah.
Yeah. So I'm kind of thinking like, could this be lymphangitic carcinomatosis? Of course, like other things could potentially do it, but I think that would be highest on my differential.
And another fine, yeah, so the interlobular septa are thickened. They can be smooth or nodular, so I never let that sway me. But there are some nodules associated with it. The other thing is the veins that are around them are kind of distended too, and that's another helpful finding. Like, look at these veins; it's kind of shaggy in here.
Yeah.
And subtle findings that may be dependent stuff. But yeah, here's the bone scan. So.
Okay, so bone scan looks like we have anterior and posterior projections, and you can see that there's just a lot of tumor disease within the axial and appendicular skeleton. So some osseous metastatic disease.
Yep.
And we can also see another focus, that most prominent focus I think is in that femur there on the right.
Yeah. So what do you think the diagnosis is? It is lymphangitic tumor. What do you think?
I think it's probably my best guess would be breast cancer.
Yeah, that's a good thought, except it's a male.
Oh, okay. Then I don't know if I think prostate cancer does a lot of osteoblastic metastases. I haven't seen it do much of lymphangitic tumor spread.
Well, it does. Sometimes it does.
Okay.
Yeah.
Okay.
That was just for fun.
Okay.
If you have to bet, always bet on lung cancer, because lung cancer is more common.
Okay.
Because it lives right there. But yeah, this is prostate. You're right. Prostate to lung is not very common, but it does occur. And it usually occurs,
especially.
Yeah, it usually occurs though when they have bad bone disease.
Okay, got it.
Yeah, that was just for fun because I happen to have saved the bone scan. But yeah, this is lymphangitic carcinomatosis. Your differential, of course, is edema. When you see an entire lobe or area with septal lines, the other thing to look for is a central obstruction. Because if you have a tumor that's taken out the vein, you'll get what looks like edema. But this is too sporadic. If you look on the coronal, it kind of doesn't follow anatomy normally. So to me, this is a good thought. They may have an effusion. They may have other mets that help you out. But if it's bilateral dependent, it's probably edema.
Okay.
All right.
Okay, so it looks like here we're showing off a frontal and lateral chest radiograph. And I see kind of a opacity adjacent to the left hilum there. And also on the lateral radiograph, there's a opacity centrally as well.
Mm-hmm.
I'm not really seeing the vessels through it. So I think it's arising from the hilum and as opposed to the posterior anterior mediastinum.
Right. Plus the lateral helps you.
The lateral helps me too. Yeah, it localizes to the middle mediastinum. So I think this could be like, it could be, an engorged pulmonary vessel on that side. It could also be like just lymphadenopathy. I guess if you just had isolated left-sided pulmonary arterial enlargement, it could be pulmonary valve stenosis.
But you'd expect the right heart to get big, right?
Right, the right heart. Yes.
And the main PA segment as well. So I like and it's kind of lumpy bumpy.
Yep, agree.
So unilateral lymphadenopathy at the hilar level, young patient, right?
Right. I guess you'd have to think about like some malignancy or something like that.
Yeah, but pretty rare in a young patient, but it does happen. Like I said, mets from pelvic tumors, you can always think about. So maybe a met from a testicular, but let me show you the CT. The CT doesn't contain the hilum for whatever reason. I couldn't find the image that had the hilum. I think I only had an abdominal and the neck CT, and that's why.
Okay. So we can see just a diffuse, a lot of lymphadenopathy in the superior mediastinum. We also see that, like just that superior aspect of what the opacity I think we were seeing there, and some lower neck adenopathy as well. In the abdomen and pelvis, I think we see some low density lesions in the spleen there, and we also see and I'm wondering if that liver is big, but I don't know. It's kind of bothering me a little bit.
Liver's okay.
Okay, all right. So I guess in a young patient, I'd be really thinking about like Hodgkin's lymphoma.
Yeah, but look at the nodes.
They're centrally necrotic.
Yeah, and this one even has a little bubble in it.
Okay.
They're very necrotic, right? And Hodgkin's lymphoma is like nodular sclerosing, right? So it tends to be dense.
Sure. So I guess I'm a little stumped here. I guess it could this be like some sort of like infectious TB or something like that?
Yes. Yeah, TB lymphadenitis, scrofula.
Oh, okay, interesting.
Yeah. This is obviously more than just scrofula because it's
like everywhere.
Yeah. So when you see necrotic lymph nodes, it's usually tumor or necrotic infection. And a young patient here in the spleen should tip you off too as well that this is probably infection. There's some other causes of it as well, but TB would still be the most common. All right. I have no idea how many more cases I have. I'll go as long as people are interested in. I know some people probably have to go, and feel free. I will not have my feelings hurt, but I will go till we finish the stack if people want.
That would be great. I think.
Yeah, whoever wants to go next.
Okay, so then next we're back to Eamon.
Hi again, Dr. Kanne.
Hi, Eamon.
Okay. All right. So heart. Well, I guess it's normal size. There are bilateral, predominantly perihilar, reticular opacities.
Mm-hmm.
I do not see any pleural effusions. There doesn't appear to be a lot of bronchiectasis.
Right.
The upper lobes, the upper lungs are relatively spared. And looks like a young patient. Don't really see lymphadenopathy. And on the lateral, just trying to see if I can find any additional findings, or if I can narrow down.
Yeah, it just confirms like no lymphadenopathy, no effusion.
Yeah.
So a lot of lung disease in a young patient who you can see it's a PA and lateral, so they're not in any real acute distress.
Yeah. So the differential would include, I guess, interstitial lung disease.
All 187 of them.
Atypical infection, maybe.
Sure. Lots of different things, right?
Yeah.
Without history, without anything else, it's really hard. There's a bunch of white stuff in the lungs.
Doesn't seem to be a cardiac patient either.
Right. So, and again, it's a PA and lateral, so it's unlikely to be somebody in acute distress. There's no oxygen. We don't see EKG leads, just some snaps from a gown.
Yeah.
So it's unlikely to be things like hemorrhage, edema.
Yeah. My feeling is that it may turn out to be like the pulmonary manifestation of a systemic disease. But
okay. It's a good thought. I think the CT is going to help you.
Okay. Oh, all right. So this is the, I think this is what we call the crazy paving appearance. And then when we see this, we think of two things. And those two things are pulmonary alveolar proteinosis if the patient has history of smoking. And then there was something else.
Well, actually, it turns out the differential for crazy paving is quite broad, and it's pretty much anything that gives you ground glass opacity. It's just filling of the lungs, and you happen to get septal thickening and intralobular lines at the same time. So, but the clue here is the fact that there's normal lung interspersed. Now, not as much in this patient, but this is one of the better crazy pavings I've ever seen. So this is what it is. It's just ground glass with some lines on top of it. So I always think about it in the same differential as ground glass opacity, because you're really displacing a lot of air. But we have perfectly normal lung, no effusions, no lymphadenopathy. It's an outpatient. So this geographic distribution is classic for alveolar proteinosis. Now, it turns out there's no real correlation with smoking. I know you mentioned that. So I don't think of smoking as really, it doesn't really play into that. It's rare, but we're pretty good at making the diagnosis. Now, other causes of crazy paving, you have to think, okay, in acutely ill patients, edema sometimes, hemorrhage, especially when it's about 48 hours old, because what you're seeing is there's still blood in the alveoli, but now it's starting to be cleared through the lymphatics. It's been described in lipoid pneumonias. It's been described in, aspiration in there, but drug reactions. But again, it's usually just in that ground glass distribution. But this geographic sort of random, and it's usually a walkie-talkie patient, as they would say, and their symptoms go on for months and months. So how do you diagnose it?
BAL.
BAL, yeah. Don't ever let anybody do a surgical biopsy. It's unfortunate when that happens. And that's also how you can treat it. You can do a whole lung lavage of like 30 liters of saline, and they remove all this sediment. And then it's associated with an autoantibody. You know what that one is? Like 95% of the time.
Was it C-ANCA?
No, it's associated with an autoantibody to GM-CSF, that granulocyte monocyte colony stimulating factor.
Oh, okay.
Yeah. And then there's some rare secondary forms, and then there's an extremely rare genetic form, like you can see in like babies. So some of that neonatal surfactant problems. So yeah, so it's usually very rare, but it has such a classic appearance, and they love to put it on the exam, although many of you may never see it in your entire career. You know, I see a fresh case every couple of years, and I'm at a tertiary center with a fairly busy pulmonary department, so you can imagine it's not that common, but always a good one for the test because it has such a good appearance. All right.
Okay. Let me minimize this. So I think there is some air trapping in the left lower lobe, as well as cysts of various sizes over there. The airways, okay.
Yeah, I was gonna say the lung is lucent and there are cysts in it. What else do you notice about? What do you notice about the vasculature down there?
Oh, looks like the pulmonary vasculature looks engorged on the left, but it's more on in the anterior aspect.
Right, where the lung is normal.
Posteriorly, there's actually less vascularity related to the rest of the lung.
So abnormal vasculature, abnormal parenchyma, and some funny cystic spaces, all in this, and the rest of the lungs look fine.
Okay, like maybe like a congenital. Okay, so what do we have? And this is an adult patient, though. So it's not one of those. Oh.
Okay. Well, if you're people born with things, they grow into adults, so you can get funny congenital stuff. I see it all the time.
Not all of them die.
Yeah.
Yeah.
No, most of them don't.
Congenital pulmonary emphysema, that would be more likely to be in the upper lobe.
Right, and it's not truly emphysema, it's congenital lobar overinflation or hyperinflation, so it's usually an airway problem. There are some other alveolar issues that go along with it, but those usually present in childhood at birth within the first month, and they usually end up resecting them. But this is another congenital lesion that we typically just ignore in adults.
Okay. I think I might have found it. Is it CPAM?
It's a CPAM, congenital pulmonary airway malformation. So yeah, this is the so-called Stalker 1, the macrocystic. So these are the kind we see in adults because nobody ever does anything about them because they go undiagnosed, right? I mean, they don't cause symptoms and they're not associated with anything usually. So patients can grow into adults and we pick these up incidentally. Now, if they detect it on an infant, the pediatric surgeons like to take these out, but I'll tell you our thoracic adult surgeons adult thoracic surgeons don't like to take them out because they've been there for 40, 50, 60 years and not causing problems. The malignancy association is somewhat controversial, definitely with the more atypical types, ones with solid components, but in these purely cystic ones, at least where I've ever practiced, we've just left these alone. But it's disorganized lung. The best way to think about it is like, it's analogous to multicystic dysplastic kidney. It's just abnormally formed lung. It doesn't function. There's cysts of varying sizes. There's just sort of disorganized parenchyma. The vasculature is very underdeveloped. It doesn't help in gas exchange very much. So we just leave them alone.
Okay.
All right. Is that 3?
I think it was 2 or
you can have one more then.
Okay. So there is this well-defined it's not water intensity, but probably cystic, slightly higher than density lesion in the subcarinal region. So it's probably like a congenital, like embryologic duplication cyst. And because of the location, I would put, oh my God. Esophageal duplication cyst.
So most esophageal duplication cysts occur near the esophagogastric junction. They occur down low.
Oh yes, sorry. That was.
This is the most common
location.
location.
So then it is oh my God, tracheal duplication cyst.
Close. What lives right next? It's below the carina, so it lives next to these two guys.
Bronchial.
Bronchogenic cyst, yeah.
Bronchogenic cyst, yes.
Yeah. Yeah, well, one way you can get out of this, if you ever in a case conference, just call it a foregut duplication cyst, and they can't argue with you because you're technically correct. Yeah, so this is the most common location of a bronchogenic cyst. They usually take them out because they present with pain or shortness of breath because they do have mass effect. Like that pulmonary artery is going to get squeezed. They just do a VATS, shell them out, and typically you're done. And if there's any question, sometimes they have dense liquid inside of them because of protein or hemorrhage. You can always do an MR to prove they're cystic. But if you're going to take it out anyway, many surgeons will just pop it right out, and you don't need to fuss around with additional imaging. So yeah, young patients. The second most common place is right paratracheal, and the main pitfall in that is sometimes you got a high riding pericardial recess that can form in that location. All right. I know we're getting close.
We're back to Elmira.
All right.
All right, so we have an anterior chest mass. It has calcification in it, or are those calcification or some metallic?
It's presumably some mineral of type, so it's presumably calcium.
All right. Chest wall mass.
Where's it arising from?
It looks like it's coming from. Oh, okay. So ring and arcs. So this is chondrosarcoma.
Yeah,
it's coming from.
I've yet to ever see the rings and arcs that people talk about, but yeah, it looks like it's irregular, coarse looking stuff. It's arising from the sternum. There's some periosteal reaction, maybe, or maybe that's just matrix. But yeah, it's a chondrosarcoma, and so that's the most common malignant tumor of the chest wall. And 2/3 of them arise anteriorly because that's where all the cartilage is. But they can form in ribs, rarely in the spine and scapula. When they don't have matrix, of course, it's harder. But yeah, chondrosarcoma.
All right. So there is an abnormal contour of the right lung, the right heart, on frontal and on lateral. I'm not sure if I see it in the posterior triangle, so I'm gonna go with I'm trying to figure out if that's something that is overlapping the heart. So probably, and it's so well. So that's like such a well-defined triangle. Are these the only images that I'm gonna?
No, I have a CT.
Okay, so probably.
What occurs in this location?
So I don't see anything to on the lateral to call it hernia. So on this side, maybe that's like maybe this is a pericardiac cyst.
There you go, pericardial cyst. So 90% of them or so occur in the right cardiophrenic space. And you're right, there's no gas in it, so we don't see any bowel. And it's subtle. You probably can't see it, to be fair. I think on a PACS monitor and in appropriate lighting, you could probably appreciate that it's a little bit denser here than normal, but that's to be forgiven. But yeah, classic appearance of a pericardial cyst. Don't touch them. Don't do anything. You don't need an MR. They can change shape. They're pretty pliable. So if the patient's upright versus supine, don't let that worry you. Every so often you'll follow up the CT for maybe some other reason and it'll be gone. And that's because it's not truly a cyst. It's a diverticulum. It's drained, and sometimes they'll fill back up again. I've seen that more than once. It kind of throws you for a loop because you're making sure you're looking at the right patient. But yeah, that's where they are. Benign, leave them alone. All right, that's it.
All right, thank you so much. Like you did 2 hours and 15 minutes straight. Thank you.
Oh, you guys did great. You did really well. I think everybody's going to be prepared. And remember, you're all good at test taking, so use all those skills. But chest, there's a lot to cover, but just think what things are common. And the last little bit of pearl I can leave you with is if you don't know what something is, guess tumor or infection. That's 80% of chest imaging.
Thank you
so
much.
If you have any questions, my email, you can reach me on Discord or email me on our department's website. It's kanne@wisc.edu. I'll be glad to answer any questions.
Thank you. I think also people can reach you out on Discord server if you. All right. So Hazel will just, I think she just did send pasted on the chat forum the feedback link. So please, all of you, please let us know what you think about all of these. And thank you for everyone who took cases. Dr. Kanne, do you have like a couple of minutes for